doing? My name is Will. This is my partner Rob, nurse flight medic over at FlightCare. So what's going on today?
Yeah, so my name's Laura. He just rolled in from EMS.
Okay.
Mom is on her way.
Okay.
6-year-old male, they found him down, laying next to a pool of his own vomit, which they kind of noted to have some like kind of white chalky material in it, but they weren't sure what it was. He's been very lethargic and minimally responsive. He's only been here maybe about 2 or 3 minutes before you guys have
Was
gotten
he at
here.
home
Yes.
when he was found?
Correct.
Okay.
But I don't know much more than that. Mom had to make arrangements for her younger child, and she is on her way.
Okay. Thank you so much.
Hey, buddy, open your eyes.
Any allergies or any medical
Can you open
problems
your
you're aware
eyes?
of from
Not
mom?
that I'm aware of. I didn't get a lot of
Can you hear me?
history. He's been very lethargic. He does like kind of withdrawn bone to painful stimuli. Your pupils are 3 millimeters and reactive
How
bilaterally.
does work of breathing?
Easy, but just shallow.
Shallow.
Yeah, I don't see any retractions.
Okay. Well, how do we have for IV access?
I don't have any access
Okay.
yet.
Do you mind if I go and grab this IV? Well, let's go and get a 20 gauge and go ahead and try for access there.
Yes,
If we're having any difficulty with that, we'll go ahead and work on an IO.
Okay.
Pressure's a little soft there as well. So
Am I hearing any lung sounds?
I heard bilateral breath sounds. They were just shallow. They sounded clear, but just a little bit shallow to me.
Okay. You said there was some chalky stuff too. Do we have any idea maybe what that was that you could have gotten into? Or
Yeah, Mom wasn't sure, but yeah, that was one thing they had noted specifically, that it
Okay.
had that like some chalky, maybe pill-like substance in it.
Okay.
Little
Anything
poke
with
on
the
this
abdomen?
side, buddy. No, the belly's nice and soft.
Okay.
I did get a 20 gauge at that left
Okay,
forearm
perfect.
for
Thank
you.
you so much. Okay, kiddo, we're going to get you checked out. Do we have any wounds? Any like bleeding or anything that we're noting? Any type of
No.
injury? Okay.
No, I don't see any trauma or anything like that.
66. All right, so what do we got for oxygen on him?
He's on 15 liters with a
15 liters.
non-breather.
Okay.
So we're going to have to try to bump that up a little bit. Let's get a nasal cannula on him too.
As well? Okay.
This is our
Yeah,
updated pressure.
I think might have to take the airway for this over here. Still not very responsive for us.
No, really just withdrawing to painful stimuli, and that is it.
And he's still down 89%. So I think I want to go ahead and prep for intubation.
Yeah,
here,
so
but
let's
go ahead.
get some fluids going on.
Okay. What would you like for
20
fluids?
mLs per kilo.
20
for
mLs per
bolus.
kilo sounds good.
Okay, and he was 25 kilos, so I will get a weight on him on the bed.
And we've tried Narcan, is that correct?
I have not given him any
Okay,
medications.
so you want to go ahead and try some Narcan first? Let's do that. Want to get some
We'll get some
Narcan
Narcan.
first?
Yep. Okay. Can you
Okay.
get
How much?
point?
Where's my Roswell?
No, wait, no, just for a second.
Yeah, absolutely. You said 20 mLs per kilo.
I'm going to take this pill from under your head here, buddy. Oh,
I'm going to give them blue.
okay. Let's slide you up on the bed here, okay? There.
Normal saline bolus. 20 mLs per kilo. That's
2
fine.
milligrams of Narcan.
Okay. Can I go ahead and pre-oxygen with the BVM before we go through the
Yes,
patient?
I have one in that white bag
White
there
bag,
for
thank
you.
you.
And you said 2 milligrams of
2
Narcan.
milligrams,
Is that IV or intranasal?
IV.
Okay, kiddo, we're going to put a little mask up here for you, okay? We're going to get pre-oxygenate and get ready to, we're actually going to do this, I'll get stuff cupped up there. We're going to hook this guy up to 15 liters right now. We're doing addressing the fluid as well.
All right, 2 milligrams of IV Narcan.
And what's my tube size for this kiddo? He says blue, right? So
I'm sorry, buddy.
no, you're good. 5.5.
All right, and that Narcan is in.
All right, we got the nasal cannula at flush rate.
Yeah, so the nasal cannula is up, and then we also have the, let's do the cup tube here. Okay.
We got a PEEP valve on here. We got a PEEP valve on there.
This could be a
Okay, there's our PEEP valve.
Yes.
See if we can get that oxygen up a little bit.
We work on that. I'm going to pull up the sedation here, the intubation.
I'm going to dial that
Yeah,
to
if you
5
give me
first.
a dosage, I can do your meds for you.
Absolutely. So it looks like we're going to go ahead and work with our 63 mics of fentanyl, and then we'll go ahead and go with, I apologize, let me take that back. Let's do 6.3 milligrams of etomidate. We'll do 40 milligrams of Sux. I do want to have some atropine as well. You can pull the atropine up. That's going to be, let's see here, 0.42 milligrams. So we'll do that as we're getting ready and give it prior to the Sux so we don't drop that.
Okay, so 6.3 milligrams of etomidate, followed by 0.42 milligrams of atropine,
Yep,
and then or 40 milligrams of succinylcholine.
Yes.
Okay.
Still got hypotensive and bradycardic. Let's get that blood pressure before we try to
Yeah.
sedate him.
Yep.
So we got
Do you wanna-
fluid on.
Yep, we can go with the compressor.
Do some push dose epi. So I
Okay.
take it the Narcan didn't do anything, right?
Correct, yeah, I would.
So I'm thinking maybe some sort of a beta blocker overdose or calcium channel blocker overdose, possibly.
How did you want me to mix up that push dose for you?
So if you could take one ml of the 1 to 10,000, we're going to take 1 ml out of the 10 cc flush, and then we'll draw the 1 ml up out of the 1 to 10,000. That'll be our concentration.
Okay.
Every 1 ml is going to be 10 mics for us.
Okay.
Again, if I'm looking here,
And down that peep up to 15.
looks like our rest dose is 0.21, but we're not going down that path. So do you want to try with 10 mics or 20 mics initially?
Start with 10.
10.
Okay, so 1 ml of push dose epi?
Yes.
Okay, give that to him now. Alright. That is flushed. I can bring it back up to a little bit more convenient.
Sure.
Yeah, let's switch over to a compressor.
We're getting a repeat here. See if that did anything for us. It's a little bit better. Still not happy with it though.
No.
Let's get some levo fed ready and hung, and then
Okay.
we can probably repeat that epi if we need to shortly.
Okay.
I think we probably start thinking about maybe some glucagon or something if this is a beta blocker overdose.
And some calcium too, nice calcium chloride.
Alright, we can probably repeat our fluid bolus if that's already in.
Okay. Another 20 cc per kilo normal saline bolus.
Yeah.
So we'll start our levo at 4 mics a minute,
Okay.
which is 3.75 mLs an hour for this guy.
Okay, so start leave. You said it's 3.5.
Yeah, so 4 mics a minute or 3.75 mLs an hour.
Okay. All right, starting that leave-a-fed drip.
Come on, Mr. Blood Pressure.
Any issues with compliance with the ventilation? It's
No,
it's
okay.
doing pretty
We
good.
still got the same. 42 over 40s. 82
82
over 46.
So we're on our second bolus and we've done. We have the pressor going right now. We could also titrate that up if we need to.
Yeah, so let's get that pressure up a little higher.
I'm worried about knocking out that pressure with the sedation or with the intubation.
All right, so let's try another push dose epi, or we can, let's try the push dose epi.
Another
Maybe
1
try
cc.
some
Yeah.
Okay.
ketamine as opposed to our
Yeah. So it's Tommy.
yeah.
Okay. 1 milligram per kilogram ketamine.
Another 1 ml of push dose epi.
Okay. And we got our fluids going still.
Correct. And then you said you wanted to
We're going to
switch.
do 20 milligrams of ketamine as opposed.
Okay, so 20 milligrams of ketamine instead of the etomidate.
Correct.
Okay.
Okay,
Well, no, the tomdates are paralytic, so we're going to have to do it instead of our.
no, Tommy.
Oh no, it's right.
All right, 87 over 52. Let's go up with the levo.
Not sure. No. Can keep titrating that up.
Just bump it up another one, and then I think we've got to probably take a shot at it. We're better than what we started, so.
Can we grab a second IV on him as well, just
Yeah.
if we have a moment while we're doing this? We'll also be prepared to do like an NG as well as grab a Foley for him.
Okay.
If the temp's good, we can do get a temperature on him initially as well.
He was 36.5.
He's bradycardic. Well, he's not bradycardic. He's older. He's 6. So.
I'm gonna poke on this side, buddy. Okay, second IVs established.
All right, we're not getting any better here.
Okay.
So,
I'm going to prepare.
yeah, let's do that. We'll do a consult for the physician about a potential reversal of a potential beta blocker, calcium channel blocker overdose.
Okay.
So I'm thinking glucagon to start with.
Consulting physician for potential calcium channel blocker overdose.
All right, we're ready.
Okay, I heard
And
back from
visualizing the
the
cords, work through the cords.
physician, and you can give 0.05 mg per kilogram of glucagon.
Okay.
I have the tube.
Okay, thank you. I'm going to grab your stethoscope here. How are my lung sounds on the left? On the right?
See chest rise.
Okay. Negative epigastrium as well.
Yes, I hit negative over the epigastrium,
Okay.
yes.
Let's grab our entitle real quick.
Correct, it is inflated.
Well, I'm sorry, let's just do our regular entitle. We've been doing that right after the initial. Thank you, sir. And then we'll get our tube holder.
Yeah, your tube is secure.
Secured, okay, thank you. How's my entitle showing? Thank you.
And I do have your transport ventilator there for
perfect.
you to set up.
Okay.
You can well, there's a table right there next to you, so you don't have to work on the ground.
Yep, no worries.
When you set your peak, set that at 0 for our
The
simulation purposes. Yes, and your FiO2 at 21%, but then you can verbalize what you would want as far as your FiO2 for your care.
So this guy's all prepped.
Switch this off to somebody.
Yeah, I can take it.
Put that there.
I did hear back from the physician for your glucagon dose, and they said you can give 0.05 mg per
Okay.
kilo of glucagon.
Has that not been given?
So he's 20.
No, it was during the intubation.
Okay.
I wanted to confirm that with you
Okay,
before.
go ahead and give that. Well, she's in.
Okay, so our kiddo here, our ideal body weight's going to be 20 kilos here. There we go. Okay, I'm going to set my peak to, we'll do 5 for initial peak. I'm setting down to 0.48 here as well. FiO2's at 100. I'll go ahead and start ventilation. Oops, let me switch the mode here. Confirm. Yes, here as well. Confirm.
Are we actually hooking it up or no?
Yeah. Mm-hmm. And then you can
gotcha.
drop your FiO2 to 21%.
Got it. Yep, I got you there. Thank you. Sorry, I thought you had that.
No, that's okay.
Well, that looks a lot better. And then, let's say, for example, if we're getting a low exhale tidal volume, we can go and increase our percentage of minute volume here to look for, to hit goal as well. So we've had 2 fluid boluses where we have our norepinephrine infusing. We've done 2 push-ups at these. Where we have calcium gluconate was given, and just one time or twice?
Just once.
Just once, okay.
Of glucagon. Hi, this is Laura.
Hi, I think my son is with you guys.
Oh, okay, yeah, I have the team here for you. It sounds like the mom is on the phone.
Oh, good.
Hi, Mom.
Hey, what's happening?
Hi. Well, your son was brought in by EMS. He's a little sleepy, so we went ahead and put a breathing tube down his on a stroke to help him breathe. Can you give us any information on your son?
Yeah, he's perfectly healthy. What do you think he's happened?
Okay, well, he says he may have ingested something. Is there any medications in the house that either you or anyone else takes? Something that might be pink?
Oh boy. Well, my mom, she takes cardamom,
Okay.
and she does have a bottle of cardamom in her purse, and it was like.
I'm going to get a fentanyl infusion for
Okay.
sedation. Probably can we do one mic per
Okay, that's kind of the route we're going down, so
Run.
we can treat him with that, and he seems to be improving, okay?
Okay.
Are you on your way in?
Yeah, I'm just pulling up to the door right now.
Okay, we'll see you shortly.
All right.
So, we start getting ready to package. Let's see.
So we started fentanyl for sedation for this kiddo,
Okay.
for the transport there. I think that we're in a position now where we get him situated. We've got 2 running IVs. We got an NG or OG that I can put down real quick.
Yeah, I can get those to drop for you.
Okay. Sets are looking better. We'll see that blood pressure.
That repeat blood pressure?
That's
That was the old blood pressure.
No, I think that's the one that just came
trying
through.
See if we need to address any more of that pressure. Are we satisfied with the pressure at 90?
Should be, yeah, because
Are we
it's
happy?
H times 2, right?
Okay.
So 70 plus H times 2 is your systolic. So
All
we're
right.
looking at least like 80s, mid 80s or so.
Okay.
All right, got
Thank
it on
you.
a chair. Yeah, if you just turn that off for me, that would be awesome.
Don't shut it all the way down.
Oh.
I think that's giving us a leg.
It does-
But
okay, yeah.
if we keep it like
Standby.
Standby.
and then
Sure,
just face
okay.
the screen to the wall.
Okay.
Then that way it doesn't take so long to
Okay, gotcha. No, good to know. Sorry about that. Okay.
No, I was just thinking about that because I was like, it's by the time it turns on, I feel like we're just waiting and
Yes.
waiting. So that might be a little bit faster for the next
Okay.
round.
Yeah, that sounds good.
Put it in standby mode, but have the screen face the wall.
Oh, thank you.
Okay, so first thing, not about the case full, but how do you feel?
Sad.
Okay. Yeah, that's you
No.
feel sad. That's okay.
I think I felt okay. Rod and I had a look at an infant that we transferred out of Alma that was like set in the 60s, and she was over 2 months old. And I think it was a lot bigger than the situation here. You know what I mean? Not to like downplay that. But
Oh
it
yeah,
wasn't bad.
absolutely. Yeah.
So
Real life versus
Yeah.
simulation. Yeah. So the patient was meant to be an unknown overdose that oxygen was not going to improve with anything supplemental, kind of forcing intubation, because I didn't want us to get some hands-on
just leave it like
experience
that.
with the ventilator and like
And then
setting
just
up
turn
a
the whole thing
pediatric
towards the wall.
patient.
Yes. Okay.
And then knowing that the patient was hypotensive
No,
and
she said,
right
yeah,
apart.
she said to me.
So anyway,
Turn it off.
did good communication, talking through it,
Or so if you just put it into
boluses,
standby,
epi,
and then,
talked about glucagon, Narcan, just thinking about Narcan, your fentanyl's probably not going to do anything for your transport, because the half-life of Narcan is about an hour and a half.
yeah. And I honestly was just thinking about too, like we did check a glucose. It's a kid that's in distress. Like,
Yeah. So the glucose would have been, what would you expect with a calcium channel blocker over
Not sure. I think
Yeah.
lower.
High.
Higher. Okay.
Yep, so with the way it affects the receptors in the liver and the pancreas, so you get hyperglycemia, with calcium channel overdoses. So that's why glucagon was great. And then, obviously it would be physician or poison controlled directed, but you can give IV calcium chloride or calcium gluconate to try to like offset the blood gain, see if you can kind of move some of those receptors. And then poison control does high dose insulin, actually, infusions to try to increase cyclic AMP to move some things around. So
How long do you like when you have these situations, it obviously depends on the volume of calcium channel blockers, but how long do you generally see that high dose insulin in order to help offset that and shift that?
long time. That's like
hours?
ICU
Really?
hours.
Wow. Okay.
So as far as glucagon and calcium chloride, how much should we be repeating that as far as vital sign changes?
Right. So nothing, especially if it's a large ingestion, that stuff probably won't work right away because you're going to be so saturated.
Okay.
So,
just keep repeating
so
it?
the glucagon, you can do a one-time push dose and then start a drip even, if you have enough. I don't know if these outlying facilities would even have enough. But the calcium chloride in that, I think it's like every 5 or so minutes. The glucanate's better with peripherals, calcium chloride, preferably at central line. But
Even if we don't really know what we're...
you know, that's the thing. So, and then the mom called and said, Grandma has them, and that was kind of then. But in the real world, if you didn't know, then no one wouldn't.
Can't hurt.
No. So, right. But in this situation, we're trying to kind of push you towards that bradycardic path, right? So we know it's not septic shock because they're bradycardic and hypotensive. So push dose epi, yes. And then going down the pediatric bradycardic algorithm, the pressure choice is epi. And then thinking about putting on pacer pads, might try to start transcutaneous pacing. That's not really guaranteed to be effective though either with the calcium and beta blocker overdoses, but just something else to think about as he was teetering towards the lower 60s. I wasn't going to drop him below 60 because we didn't need to do like the full, PALS algorithm, but thinking about that. So pacing may or may not help even in the real world.
That's just
So
the last ditch. All the medications working.
yeah, something else to try. But then yeah, the PALS bradycardic algorithm, epi is our master of choice for beats. One takeaway.
I think what's helpful is when we're flying to, we have that information already, so I've got doses already written down, so I don't have to fumble around with the, that's always helpful for me,
Yeah, absolutely.
because I can hardly read that damn card as it is.
Yeah, I would say for me, like I pulled my phone out later than I generally would, and we usually have our phones and the protocols are there and everything, so there's a lot more comfort in going to those protocols and working off the Braslo, for example, because it's not, it's aligned with what we do, but it's not step by step, but it's not exactly where we're at with everything. So for me, I was more comfortable when I pulled my phone out as far as, oh yeah, here we are. Well, there's a protocol, there's this and that. So just having that resource.
Use your resources. Yeah, absolutely. All right, good job.
Okay, thanks so much.
Thanks. You can just leave them on.
Okay. Thank you. Appreciate it.
Thanks.
See you
Yeah,
again.
absolutely.